Good morning. I'm Tanu Rao from Sydney, and today I want to talk about robotic bladder dissection. This is a case of a lady who's had previous 3 cesarean section, and I want to concentrate on how we can dissect the bladder head-on centrally. Now, there are different ways to do this, as we've discussed before: lateral approach, central approach, and a combination of both as well, I suppose. But over here, we're just going to do central approach. I'm just taking down the thin adhesions. These are thin, flimsy adhesions that we can see. I know they're transparent, so it's okay to do that. But you will see over here, I'm trying to also see if lateral approach is feasible, trying to negotiate that. Usually when I use my fenestrated grasper and try to tunnel beneath the UV fold, I'm successful. But over here you can see that it's a bit difficult, which is why I've given up and I've decided let's just do this head on. So you just go ahead and take some brave bold cuts. As you can see, a bit of yellow or the fat. So this is the fat that surrounds all the visceral organs in our body, and the bladder also has some amount of fat cushioning it. So I feel very happy when I see this, because I know that I am not in the bladder, I'm around it. Fat is okay to be cut on, and you can do gentle movements of dissect just to see if it gives away and rolls back over your manipulator cup, or if you don't use a cup, without it. Now you can see with the fenestrated grasper, when I hold up the bladder, the vertical fibers really stand up, and I think we've gained access into the cervicovesical fascia on the left side. This is what I want. Even a tiny access is enough, because I know that we can exploit this later on. So once that's done, you will see throughout the video, whenever I need access, I'm always giving good traction on the bladder. So firm but gentle traction. Sometimes when you hold it harshly, it may begin to bleed. So make sure you're gentle, but it should be in a way that the fibers are vertically taut, so that when you make that cut, they get dissected nicely. So even over here, I've used the cardia forceps in my 4th arm, and I've also given traction with my other arm on the uterus. So traction on both the sides, so as to really lengthen out those fibers, and thus my cuts become a bit more precise. Over here you can see that I'm just not blindly cutting, I'm doing fiber by fiber dissection, because I'm not completely clear as to where we are. But when I'm in the white or the bald eagle sign that we call it, the cervicovesical fascia, there I use comfortably my forceps. Right over here, as you can see, I'm comfortable just using a bit of blunt dissection, just to make sure the fibers roll over. But if you're not sure if there are adhesions, make sure you do sharp cuts rather than blunt, because it will tend to bleed a bit, and then you will lose your plane as well. You always counsel the woman, look, there's always a risk of bladder injury. So even with sharp cuts, if that does happen, you can identify it. Always make sure you either backfill the bladder, or you do a cystoscopy and do an intra-op check of bladder integrity. So if you do find a defect, you can sew it up then and there itself. With sharper cuts, it's much easier. With blunter cuts, it's a bit ragged, the margins. So the central bladder dissection is almost done. Now all we have left was the rest of the uterus. Thank you for watching. I'll be back with more.